So hello everyone and welcome back to Simcyp Technical Webinar. My name is Pan, part of the Translational DMPK group at Simcyp, and I'll host the session today. Before we start the talk, I'd like to kindly request that everyone stays muted during the presentation. Should you have any questions, feel free to raise your hand or post your queries in the chat box. We will have a dedicated Q&A session at the end, where we'll address all of your questions. And we're recording the presentation today, which will be available on YouTube shortly. Next slide, please. And it's my pleasure to introduce today's speaker, Dr. Ian Sorrow. Ian is Associate Principal Scientist in Mechanistic Modeling Group of Simcyp, and he has an academic background in mathematics and physics, and brings over 12 years of experience in PBPK modeling, and been with us in Simcyp in the past 5 years. And I'm glad to have him with us today in today's session. He will give us an overview of this mechanistic inhalation model in the Simcyp simulator, and also followed by a case example of Budesonide for the dry powder inhaler delivery. And without further ado, I will hand it over to Ian. Over to you, Ian.
So, thank you for the introduction, Xian. I'm going to go through an overview very briefly of the ADAMI model. Just a few slides on that. Then I'll move into the talk about the budesonide case study and give this talk about what information is available for budesonide for parameterizing, so this dry powder inhaler, and show how that's entered in the simulator. So a lot of the session will be just a demo of the simulator, showing how it's parameterized. And as I go through the different components in the simulator, I'll talk about the different features and the different options there are. Okay, so start. So the ADAMI model, this kind of represents 3 key processes. So this first process is kind of deposition. That's to 4 regions of the respiratory tract. There's the mouth, throat, or extrathoracic region. There's 2 airway regions, so upper and lower, and then the alveolar region. And so the user can either enter values for those the deposition in those regions, or there is a predictive model within Simcyp. The second process is relevant if you're using solid particles, is the dissolution of those particles. So this is a similar process to what's in the oral model in terms of how the dissolution is handled. And then the third process is in the transport of the dissolved compound. So between the fluid where it's deposited and the lung lining fluid into the tissue mass and then into the blood. So those processes then, I'll show how they map onto the overall kind of model structure. So starting with the inhaled dose, as I said, then we have deposition. So different fractions of that dose are deposited in the different regions. So there's the extrathoracic region, and then the 2 airway regions are the bronchial and bronchiolar, and then the main lung regions, the alveolar interstitial. Not all of the dose is necessarily deposited in those regions, depending on what the device type is and how it's being represented. We can have a fraction of the dose can be exhaled. So after deposition, so what's deposited in the sort of mouth, throat, extrathoracic region, that's transferred to the oral model, so it's assumed kind of swallowed. And then the other regions, so we assume that deposition occurs in the fluid of the different regions. So we have the upper and lower airways, and then the kind of lung is then split into 5 lobes. So 3 on the right and 2 on the left. And the reason for this is actually kind of, the original lung model in the simulator was used for looking at tuberculosis treatments. So you can define the frequency of granulomas within different lung regions. So the same model has now been adopted for the inhalation models rather than 2 different lung models. So the deposition occurs in the fluid region. So there's particles that dissolve if you're using solid particles, or if there's a solution selected, then it's kind of the dissolved compound is directly deposited within the fluid. And then there's diffusion, so passive transport between the fluid and the tissue and the blood, and you can also specify active transport as well, both apical and basal. And of course, as then you have transfer from the lung model into the systemic blood and the other tissues in the body. And there's also clearance from both the alveolar region into the lower airways. So this represents macrophage clearance, and so the default is for a very low rate of clearance from the alveolar to the lower airway. And there's higher clearance then, that's representing mucociliary clearance from the lower airways to the upper airways, and then from the upper airways to the mouth-throat region. So if the first order oral model is being used, then it's assumed that what's cleared by mucociliary clearance is deposited in the then transferred to the oral model. But if ADAM is being used, and then it's assumed that the mucociliary clearance from the upper airway, kind of the compound's lost route. Okay, so that is kind of the overall structure of the model and the different processes. And I'll talk about them more as I go through kind of actually the demo in the simulator. So we'll now move over to the kind of case study. So looking at budesonide. So there's a treatment for asthma and chronic obstructive pulmonary disease. And so for this compound, there was a previously published model looking at IV and oral absorption. This is Effinger et al. 2021, and you can see a prediction against observations for an IV dose in the plot there. So for the case study, I'm not going to talk about the kind of systemic and phys chem and elimination parameters of budesonide. I'm just going to talk about the inhalation kind of parameters and the information that's available. And so that's what on this slide. So the particle size at the top there, that's the main parameters for determining the deposition, at least using the predictive model, is the particle size. It is, well, the parameters that describe the particle size. So typical parameters are the mass median aerodynamic diameter and the geometric standard deviation. This is normally what's kind of returned from sort of a study using an impactor when we measure the size of the particles. For the particular literature that I've got for this budesonide case study, only the mass median aerodynamic diameter was given. So you can see that in the table there, we can use that mean value, the 2.19 micrometers. They didn't say what the geometric standard deviation was, but they did say that negligible particles with aerodynamics are present greater than sort of 5 micrometers. And so that's not typical. Typically, you'd have an MAD and a GSD. Another thing, what the dose that should be entered in the simulator is the delivered dose. So this is what actually kind of leaves the inhaler device and actually enters kind of at least into the mouth throat. And so that's normally there's a residue within the device, and in this case, so it's like the delivered dose is 89% of the nominal dose. For permeability, in this case, there was a Transwell study done using a carcinoma cell line derived from the lungs, the CALO3 cell line. And so there's permeability value for that, and we're going to use the mean value from the apical to basal and basal to apical kind of studies that were done. For the dissolution, so the only parameter that we're going to need to parameterize the dissolution is the solubility. I mean, there could use predicted value for that, but there is at least an aqueous solubility value available. I think it is possible that so the solubility we enter is the lung fluid solubility, and it is possible to measure solubility within, say, an artificial lung fluid, but that wasn't done for budesonide, so we're just going to use the aqueous solubility. Okay, so I will switch over to the simulator and show how that information is entered into the simulator. So we've got it set up so that all the parameters of the Effinger study, such as the phys chem and elimination, have been entered already. So now we just want to look at looking at the trial design, so how we move to inhaled. So I'm using version 25, which hasn't been released yet, but it's going to be released imminently. But pretty much everything I say is going to be as applicable to previous versions, but there's just a couple of new features that should be present in version 25 that I wanted to talk about. One of those is that just inhaled vapor is going to be a dose that's going to be selected. So I'm not going to talk about that today, but so this is something that could be used for simulating anesthetic gases. But we're doing an inhaler study as a dry powder inhaler, so we use the inhaled option. So then in the absorption section, then we go to lung to activate ADAMI. It's just the option there. Some defaults to have to be selected, enabled, and included using the permeability lung model. So we click yes to activate that. And so we'll talk about the permeability for start. So that I can either go to the transport to the lung screen, but there is a button to go there from the ADAMI screen. So you see that the permeability limited lung model is activated. And so the permeability is set in the top half of the screen. So you can either enter a user value, either kind of a global value for the basal and a global value for the apical, or individual values for the different regions by unlocking the padlock. But we can use the CALO3 value. So we can use the predicted, and that opens up the option for using CALO3. And so, the number that we have from that study there. And you can see that the CALO3 value is pretty much transferred across to the what the permeability value that's used. And this is true for a neutral compound, which budesonide is. So if we go to the physical and blood binding and just show what happens with a compound that isn't neutral, so just make that 4. So it's quite a fairly highly ionized compound at lung pH. You can now see this value, the permeability value is increased a lot. So originally, it was this kind of the 0.0472. That's much larger. So the reason for this is that let's assume that this value that's entered is the effective permeability of the kind of total compound, both unionized and ionized. Whereas this value, the permeability in the model, is only the unionized compound that crosses the membrane. So to achieve this value of the effective permeability for both unionized and ionized, the value for the unionized permeability has to be much larger. Okay, but budesonide is neutral, so we change that back to neutral on the PhysChem screen. So other options for permeability, there's CACO2. So this is a correlation specified between CACO2 permeability and CALO3 permeability. So it's not so it's different if we enter the 4.72 for this. So you get a different value because there's a correlation between the two rather than not using the value directly. And there's also a predictor, PhysChem-based predictor. So you just specify the log D, the compound at a pH 6.5, and the hydrogen bond donors. But we have CALO3, which is probably the best one, I guess, of the most lung-specific value that we have. There's the unbound fractions that are specified on the screen. So the fraction unbound in the lung, in the tissue. So this predictor is similar to other predictors that are used for other permeability limited organs. So it's, the methodology behind it is similar to what derived the partition coefficients on the distribution screen. So you can also enter user value for that, of course. So there's not a similar predictor for the fraction unbound in fluid. So one thing we have done for some case studies is extrapolated from the fraction unbound in plasma. So it assumes that all of the binding is to albumin, and both in the plasma and in the lung fluid, and then taking account of the difference in the concentration of the albumin, kind of extrapolate a fraction unbound in fluid value from that. But that's still something I actually want to look at, maybe different predictors, if you can get some information on that to produce a better predictor for that. So typically, a lot of the cases use the FE fluid of 1, but it's something that it's good to look at the sensitivity of that after when the model's finished. So look at sensitivity analysis, either local sensitivity analysis or global sensitivity analysis, include the FE fluid. Then underneath this, so we also have kind of the transport section where we could define transporters if we want to. Okay, so that is how the parameters for the transport of the compound. So we're going to go back to absorption and now look at the formulation options. So, so if you were looking at a nebulizer study, you're most likely to use a solution formulation, but we've got a dry powder inhaler. So we want to choose the powder option. And then there's two options for looking at the diffusion of the powder. So the diffusion layer model, which is the one we're going to use for budesonide, and there's also a dissolution profile. So there isn't a dissolution study that we found for budesonide, but if there was, we could enter the profile for that, either through the discrete or a fit of viable function to get the dissolution profile. But we can use the diffusion layer model. And so if we click on diffusion layer screen, so this is the same formula that's used, or same equation that's used for the oral model. So I'm going to parameterize this model. It's just use the aqueous solubility. So there's not a lung fluid solubility that's available, so just going to use the aqueous solubility. And so it's not actually a predictor specific for lung fluid. So the predictor is just the aqueous solubility. We use keep the other parameters default, including kind of the diffusion coefficient of the compound with budesonide. So there is a screen for luminal degradation. So if the compound does degrade over time in the lung fluid, you can enter that degradation here, and we've got different values for the different regions. So now I'm going to move on to deposition. So deposition is this is the most complicated part of the ADAMI model. I guess it's something that's kind of a little bit different from other permeability limited tissues. So I guess in terms of device, you can choose the inhaler or nebulizer. So for budesonide, we're interested in inhaler study, but just to click on the nebulizer for a moment. So there's a parameter here for setting the duration of the nebulizer administration. So it could be that the total dose is administered over a period of like maybe 10, 20 minutes even. So you can change the time of the administration there, and then it acts more like an infusion dose into the lung fluid. Whereas an inhaler, then it seems like an instantaneous transfer of the compound into the lung fluid, or at least the particles in this case. So there's a number of options there for the inhaler. So I'm going to talk about those in a moment. First, we'll go down. So ultimately, what we want to predict is the regional deposition fractions. And so by default, the predictor is being used. The user can enter their own values by locking that padlock. So I said the key parameters for the particle size is the deposition is the particle size. And typically there'll be information on the aerodynamic diameter rather than the geometric diameter. So you can see there's a difference between the aerodynamic diameter and the geometric diameter, which we double this value there. And there's a couple of parameters on the end here, the shape factor and density. So often these aren't known, so often these are kept as a default. But the way they're used is to convert the aerodynamic diameter to the geometric diameter, and then the geometric diameter is the diameter that's used to define the particles, or at least the geometric radius is used to define in the diffusion layer model. So consider the difference between the two is that the aerodynamic diameter is the diameter of particles at unit density that's spherical. That's still at the same velocity as the particles being measured. So if we change this to unit density and the shape factor to 1, so this represents the spherical particles, and then we can see then the geometric radius is half the aerodynamic diameter. But we'll just change this back to the defaults. And so the parameters that we are going to use to parameterize the distribution is we're going to use a polydispersed particle distribution. So we click on the polydispersed value, and then we have, so new in version 25 is that we can enter the MMAD and GSD directly. So I'll talk about in previous versions how you'd enter this information in a moment. So normally you would have an MMAD and a GSD value. So although we didn't have one for this particular study, I've looked, and so that value of 1.7 gives us that nearly all the particles are next to 100%. Kind of other particles are less than that 5 micrometers. But typically, as I said, you would have that GSD value would be measured. So previously so what happens with this is that the MMAD and GSD are converted to the radius of the geometric radius mean and the CV for this log normal distribution. So in previous versions, what you have to do is do the conversion process outside of the simulator and then enter it in this distribution function option by opening this padlock. But now in version 25, you'll be able to enter that directly. Okay, so that's entered the particle size information. You see that's updated the particle, the regional distribution. And then, so we have some other parameters here. So one of the key parameters is the fraction nasal. So this is obviously the fraction going through the nose. So because we're using an inhaler, we want to set that to 0. Because that's everything's going through the mouth then. There is these options for nasal and mouth, but even these are corresponding to different types of breathing rather than actually everything going through the mouth, everything going through the nose. So this is sort of the default prediction. We can see in the regional deposition fraction. Oh, just mentioned so there's a parameter inhalability here is not particularly relevant for pharmaceutical devices. This is more for breathing from the air through if you're interested in inhalation loss because of wind speed. But for most pharmaceutical devices, that just stays at default 100%. So this is kind of the prediction that we've had from version 23, because there wouldn't have been at least different options for some of the different inhaler options. And we see that actually using this for budesonide, making a prediction, hopefully I'll show you on the slide in a moment, that actually gives quite a good prediction for the PK for one of the studies. But actually the regional deposition fraction is not very well predicted. So we see the fraction total is 55%. That means 45% is being exhaled, and is predicted to be exhaled. But there's actually a measurement, an imaging measurement for budesonide, and that fraction is more like 0.2% in the study. So this is over prediction of exhalation. And also in that study, they measured what was deposited in the extrathoracic region as more like 76%. So we're getting this under prediction of what's deposited in the extrathoracic region. What's deposited in the lung is actually reasonably well predicted. And you see that's why we get kind of fairly good predictions for the PK. And it's partly because this fraction that's the under prediction doesn't matter too much for budesonide because it has a high hepatic first pass clearance. So what's deposited here doesn't influence the systemic PK very much compared with what's deposited in the lung. So I haven't got a lot of time left, so I'm not going to go through in a lot of detail, but I just want to talk about some of the things we've added in version 24 and version 25 to improve these predictions and make them more relevant for pharmaceutical devices. So the ICRP model, that's the default model. That was developed for tox purposes for looking at inhalation of radioactive particles in, say, a workplace setting. So using a normal breath, so you breathe in and breathe out. That's why we're getting quite a lot of inhalation. Whereas typically for a DPI, the user is told to breathe in, take a very deep breath in, and hold the breath for up to 10 seconds. So there are academic groups that looked at this and assumed that looking at that, well, certainly from the data, including this budesonide study, there's very little exhalation from a DPI. So we've added an option to look at this, the deep breath followed by the breath hold. We've just assumed that 100% is deposited in the lungs. So anything that's not deposited in the extrathoracic region or the airway regions is deposited in the alveolar region. So that fixed one of the issues in terms of getting this over prediction of what's exhaled. But then we've not got the under prediction from the extrathoracic region. But we've introduced the option to set that extrathoracic deposition. So this can be measured. So if we're obviously using like the replica casts of the mouth-throat region, or it might be the particular device that's being used. There's previously been measured for the extrathoracic deposition to be measured. So you can enter the values for that, and obviously that gives us then more realistic values for the deposition. Also, I also want to look at within the population screen for the lung. So there's lots of parameters here that describe kind of the volumes and the absorption areas for the lung parameters, but just move So I haven't got time to go through all of those. We'll just say at the bottom there is the parameters for that control the physiological inputs for the deposition. So typically the default is for just to have these just a set for males and females. And so if the CV is a 0, then all males in the population will have the same deposition, and all females have the same. But there is, introduced in version 24, there is some lung function relationships were added. So with some taken from the literature. So we've got dependence on the age, and so this is the formula for the volumetric flow rate and the tidal volume. And so we have dependence for the age and the height for the individual. So we're getting more population variability. So what I'll do now is switch back to the simulators. So not a lot of time to go through this, but these are the predictions to the clinical studies. So the top row is so there's 2 doses in one clinical study and 1 dose in another clinical study. This is just the default that I showed initially, the ICRP model default, uses that normal breath option. So for one option, it does, even though it's getting very bad predictions for the deposition, it's doing quite well for one of the studies for the PK, not so good for one of the other studies. And then with some of the new functionality that we've added to the simulator and some of the population variability, we can now capture a little bit better kind of both doses. The study that was done in so there's one study that was done in older individuals. Can see that even though the 2 doses are quite similar, that the deposition, at least the Cmax, is actually a lot higher if we look at the scales than in the study that was done in much younger individuals. And so we introduced some of the functionality that we've introduced. It looks like it's capturing some of this kind of differences in the deposition between different populations, different ages. Okay, so I had to rush a little bit at the end there. So sorry about that. So there's a lot more kind of, I haven't got time to go into the details of the inhalation models and how they work exactly. But there is, so we are developing inhalation workshop. So that's coming soon. So if you, so once that's available, you can find out more there. Okay, thank you very much. So are there any questions?
Yeah, thank you. Thank you, Ian. Now we can move on to the Q&A session. I also want to point it out, apart from this upcoming inhalation on-demand workshop, we had a scientific webinar also talking about inhalation model. So if you haven't attended that, you can listen to that one. It's on YouTube already. So we have got a question from Ryan asking how exactly the original deposition fraction predicted. Is there a CFD component to the model, or is it predicted by some other modeling modality?
No, so it's an empirical model, essentially. There is some mechanisms behind it. So the ICRP model it's quite simple. So it's not using a CFD methodology now. So it's mainly and both that model and the new model that's been introduced for looking at there's an input for the extrathetic deposition on inhalation part. So they're not CFD models. They're much simpler than that.
Okay, and we get another question from Eman, who just sent it to me. Can this model used to predict intranasal delivery to brain?
No, no. So I think it's something we've looked at. So you can, if you so go back to the simulator. I mean, you get an idea. I mean, there are some elements of the model that if you had, say, the fraction nasal, if you set that to 1, we need a long breath. You kind of know what's being deposited in the nose, but that's everything that's in the nose. It's not the particular region that's used for you get absorption that would go to the brain from the intranasal part. So no, we'd need a separate model for doing that.
Okay, and I haven't seen any further questions. And we almost done. Oh, okay. There's one more. Let's just take that one from Mark.
Okay.
How important is it to measure solubility in simulated lung fluid? The recent publication on GDC 6988 from Genentech, and that's the one we presented in the scientific webinar last month. So asking the recent publication used Savanata for this. Hope I pronounced it right.
Yeah, that's right. I think it depends on the compound a little bit. I think in that case, when we did the sensitivity analysis, it wasn't particularly sensitive to the solubility. And I think we had, but that's with pretty quite rapid dissolution. So I guess it depends on how rapid you expect the dissolution to be. So if it is quite rapid, then it's not going to be sort of a limiting factor in the absorption. So then it's probably not going to make a lot of difference actually using lung fluid. So it's probably something you can look at the sensitivity to that parameter, and if you've got an estimate of what that might be, and then you can look at how important it is to measure that. But yeah, that might be something to do first before actually measuring it in the lung fluid, the artificial lung fluid.
Okay, thank you, Ian. I think that's the last question. I haven't seen anything else coming through. So we're gonna conclude today's webinar. And thank you, Ian, for the introduction of the inhalation model. And thank you all for joining us today. Should you have any additional questions later on, please don't hesitate to get in touch with us. So our next technical webinar is scheduled for the 8th of December, and it's actually another webinar about VBE we covered in this year's technical webinar series. And this one is particularly using Piranha and the Simcyp integration. So if you are interested in it, please register through members area. And once again, thank you for being with us today. We look forward to seeing you soon and wish you all a lovely day and goodbye for now. Thank you, everyone.